We have 5 programs that are going to do the report out. And the first one, and you have 5 minutes to talk and 5 minutes for questions, is going to be Claire Brindis talking about CEHP. Is she in the room? Okay, thank you.
You'll give me a minute to... Okay. So our group talked about a bold idea that we are proposing in the area of children and policy, and that really pertains to developing a very usable, large electronic clinical and public health data set in the Bay Area to study the impact of existing community-based implementation science initiatives with an emphasis on both at-risk children as well as resilient children. And as part of this bold idea, we're interested in developing a screening tool that will assess social vulnerability, as well as produce electronic registries, as well as testing sites for pragmatic applications of electronic healthcare records, a large database that will cover both the Bay Area as well as California, and using social media and the web and other electronic forms of communication to do health education in a variety of health settings, and really engage the community in terms of being end users and partners in improving the health of our state as well as the Bay Area. So in our conversations, we spent some time talking about what are the unique strengths and opportunities in the Bay Area. And one is the excitement that we have about the fact that UCSF and the Benioff Children's Hospital on this side of the Bay, as well as the Oakland Children's Hospital, are now part of one. And that is a really new initiative and a new opportunity and a leveraging opportunity that is going to be very important for the renewal. And that this provides opportunities for collaborative science and community engagement because there's a high degree of trust in Oakland that has been really established over decades of work, as well as the trust that has been built in our community around the work that community engagement and policy has undergone. We also have a very strong strength around social science researchers on our campus, as well as policy researchers, and the idea of really maximizing technology and data. In terms of challenges, the bold idea that I just shared with you, I think, has a lot of components that need to be figured out in terms of what are the sequences. And as some of you may know, Nancy Adler from our campus has been serving on an IOM committee that has come up with social determinants of health variables that need to be added to electronic healthcare record. And we believe that working with Apex in our campus, we have an opportunity over the next year, even before the RFA is out, to start building some of these indicators into our electronic healthcare record so that we can begin to show that this is feasible in the same way that the 2 research projects that were shared by Deborah earlier today around headaches and, the other element having to do with kidney disease. So one step would be very important is to identify and create inventories about all the variety of centers that are working on children's issues, both within the Department of Pediatrics and outside of the Department of Pediatrics, whether it's the Center for Vulnerable Children, the Center for Focusing on Disparities, all the university and community partnerships on both sides of the Bay. We need to find a way to create this kind of repository. And this is an element that we're very interested in creating a child health research institute that would bring a variety of partners together across the 4 schools, across pediatrics especially, and all our partnerships. And to be thinking about also the need to do some homework in this coming year around looking at some national models that exist, for example, in Cincinnati, Philadelphia, and Boston, where there's a lot of strength in the area of children's health. And what are the electronic healthcare systems and data systems that have been established there? Can we learn something from them that would be applicable here? And finally, we raised a number of areas that are gaps right now. A very important aspect of this really has to do with bringing the issue of environment into this, because we know that children will benefit from thinking about quality of air, quality of housing, quality of environment in general as it relates to social aspects of health. Another major element really has to do with the issue of ethics and how do we bring together the issues of regulation around data systems, and if we're going to set up these repositories, what are the elements that we need to figure out and overcome, whether it's legal aspects or ethical aspects, and bringing the community engaged in terms of really prioritizing what are the issues that they want to have answered by these kinds of data systems. And to be thinking about how do we maximize the use of the electronic healthcare record to begin to help us answer a variety of these issues and communication. Thank you. Hi there. Sorry, I'm the guinea pig, so I'm learning as I'm flying the plane. So first, I'd like to see whether in the two tables that were devoted to community engagement, are there any other elements that I failed to highlight that you'd like to bring up to the rest of the audience? So let me start off with my peers and see if there's anything else that you want to add. Laura?
Do we have the technical capacity, and how can we show that we do, to bring Apex and Epic up to speed on this? And members of the innovation team were present, fortunately, but that was a really important weakness, I thought, in our proposal that we'll need to address.
And I think along with that, Laura, is really even identifying what are the data systems that are in place, to find out what the screening tools are that people have been using, and a variety of these community-based and other related programs. Maybe some of these screening tools have already taken into account a lot of social variables and social determinants.
The other one was that they're already, instead of proposing to create new apps, we should do an inventory of existing apps. So for example, Children's Hospital right now is evaluating an app that would allow people to, if you're homeless, what services are available. And most of the population has cell phones that would be useful. And so before we go creating new apps, we should be doing a very systematic inventory of the ones that exist.
And then creating a repository of that information. And we talked a little bit about that concept of apps as also a tool for recruiting community individuals to participate in clinical trials in the future, or other kinds of observational studies. Other comments? So I think the message is there something that we can start to do in the next year, and then to build on that as a strength for our proposal?
Just quickly, and I
Do you want to identify yourself?
I'm sorry. My name is Roberto Vargas. I'm staff with the Community Engagement Health Policy Program, a navigator. And you know, I understand the value of brevity, particularly in this format, but several of us talked about the importance of naming the partners. You named many of the partners, and here in the conversation there was a naming of partners, and I think that it is important to call out who are those folks across the university that can partner to support this work, and who are those folks outside of the university that we need to make sure are engaged as we determine priorities and as we implement the work as well. But just thought that it was particularly important to call out some of those institutional partners that could help us in making this happen, particularly out in the community. Thanks.
Great. Okay. Other comments or questions? We're hoping that if children are a priority, that as we hear reports the rest of this hour, that we'd be thinking about how children would be one of the populations to perhaps where we could apply and cross-fertilize with the research that you're going to be reporting on. Okay. I think we should move forward. Thanks.
Next is John Reuter for CRS.
Thanks, Alice. So I was in the CRS group, and we had a spirited discussion about the CRS proposal and limited resources and let's see. I'll assume that you've all read the proposal itself, so I won't summarize it, but I'll just jump into the 4 questions that we were asked to consider. So the strengths of this proposal, our group felt like the clinical coordinator matching service that matches availability of clinical coordinators with researchers, that was a particular strength, including that program, the audit and certification and training of clinical research coordinators. Also, the mobile nursing unit that's mentioned in the proposal. And also offering innovative options such as the use of sensors and mobile devices. We felt like that was a strength of the proposal. However, we felt that that section could be fleshed out a little bit more, and that we could emphasize the advantages of using those technological tools, and especially with regards to patient retention and recruitment and its cost effectiveness. So as to how the proposal could be improved, we felt like emphasizing training could improve the proposal, weaving training into the CRS, particularly in the areas of regulatory and compliance for clinical coordinators and nurses, as well as a kind of a boot camp, an operational training for researchers at different sites for how to conduct research at, for instance, SFGH, how to use Apex, how to conduct research at the VA, et cetera. And then another area where we felt like the proposal could be improved is in demonstrating how the CRS would be integrated with other CTSI programs. We felt like that was a gap in the current proposal. As to what foundation exists on campus that will ensure the success, we felt like the people in the CRCs are, their skills are what will make the initiative successful, so that we should really emphasize the good, skilled people that we have, and that their training leads us to, we know that we can trust the data and that they produce, and emphasize that aspect. Let's see. And then the last question, we were asked to consider what creative or innovative partnerships could be leveraged. We had some great suggestions in this area, for instance, that we could partner with large-scale pharmacies such as Walgreens or CVS as a means for a more efficient, cost-effective method for doing blood draws, that this could help patients by giving them access to participate in studies by going to their local pharmacy. So we should look into those large-scale pharmacies and seeing if we can partner with them. There was a comment at the table that we think that UCLA may have a partnership with, I'm not sure if it was Walgreens or CVS. And then Quest was another partner that was discussed. Partnering with Quest for blood draw and sample processing was a suggestion that we could look into. And then partnering with the medical center or the medical school. And I'm not exactly sure. Maybe I'll turn next to our CRS table and ask if they can expand on any of these ideas. So following Claire's example, is there anybody from the CRS group that has anything they'd like to add that I may have missed?
I think a very important point was, when we get the final RFA on what kind of what they're looking for from a CRC. And we talked a lot that one of the strengths are in fact the CRCs, especially the pediatric one, because we stand really unique among many CRCs that we have pediatric and neonatal, very experienced nurses and coordinators and a whole setup for them. But I think there was a lot of discussion on really, where's the money going to come to have a high quality, low cost CRC, and that's really critical, and there has to be really some buy-in, I think, from the medical centers to recognize that having high quality research will be critical to have a really well established clinical trials network set up and ready to go, if that becomes the primary point of an RFA.
Okay, great, thanks. Any other comments from the CRS table or the group at large? Okay, thank you.
Next up is Rachel Sack talking about consultation services. And just as a general request, if you're speaking into the mic with a question or comment, could you identify yourself so people know who's speaking? Thanks.
Hi, so I help facilitate the consultation services program, and their proposal really is focused on identifying that there's going to be expertise and services required to support next-gen research, and what those services and what that expertise might look like. So we tried to identify some of the strengths in the proposals, and we thought there were many, including the fact that it really highlights the true key areas that we know about. I think one of the biggest strengths is that the proposal is really user-focused. It was based on already some early identification from researchers that are starting to embark on these next-gen type proposals. So it's really starting to take into the account of the challenges and the gaps that exist for these researchers. We also think a nice strength of this is going to be the demonstration projects and these real-life examples where consultation services will be able to continue to define their proposal and describe their proposal based on those projects and continue to refine the needs of the researchers based on what they're learning. But they also realize that in that there's going to be a lot of learning, and is there a way that this can be kind of standard SOPized? So are there some types of standard operation procedures that can be put into place or operationalize this? So the learnings from these can be either cataloged or somehow documented, and there were lots of examples of how they might go about this, but to figure out how they actually might use that data, learn from it, and then have that moving forward. So they're not reinventing the wheel for every new study that comes through or every new research project that comes through. In terms of other strengths and areas where they can be improved is also to figure out a way that, as they're learning from these demonstration projects, is there a way to take that information and those learnings and then feed it back into APEX and those systems? So is there a standard way of collecting data? Is there a specific amount of types of information that could be collected and then actually put back into APEX, and figuring out a way to do that and somehow capitalize upon those learnings? And then in terms of what exists on campus and what can we leverage, so of course there's a lot of health expertise and expertise in the academic research services, and Doug Bell was at our table and it was very representative of that expertise. But also, and this had to be mentioned because I was at the table, so UC Braid and UC Rex, and leveraging that expertise of those representatives here at UCSF, but also across the UCs. And then also just really recognizing that this is, consultation services has expertise and really keen expertise in providing data management and analytical expertise and directing researchers then to the additional resources they need. So they can't do it all. They can't manage projects from end to end, but really focusing on their primary strengths, which really are the analytical pieces and the data management pieces. And then in terms of some creative or innovative partnerships, one of the recurring needs that came up throughout the discussion was really talked a lot about expertise in programming, but also expertise in dealing with social media. And so a couple of people brought up suggestions in terms of having internships or some type of cross-training programs with, for example, the School of Engineering at Berkeley, Lawrence Livermore, but also other big companies that have expertise in dealing with big data and dealing with social media. And there could be some partnerships forged there that would help either cross-train but also provide some resources. And then lastly, working and learning from, again, and this kind of goes back to the first point, is really working and learning from groups that are currently proposing projects to standardize data collection in the APEX systems or in the electronic health records. So for example, Barbara Mazicki, who's a pediatrician, oh, there's pediatrics again, who's a pediatrician here at UCSF, has a proposal that's looking at standardizing language for collecting data at point of care for children, and is working with researchers across all the 5 UC medical campuses to do that. So one of the strengths of that is that you have champions that know what it's like to collect these types of data at the point of care, and they're incorporating that into their proposal and their learnings. So I think that's about it. I want to reach out to Alka if there's anybody else that was at the table that wanted to add to our discussion. Any points that I missed? Nope? Nope. Okay. Any questions or additional strengths or partnerships that anybody wants to suggest for consultation services? Minnie.
So consultation services has, one of the things that's done superbly well is in effect being a front door for a particular set of consultation services, right? Both in terms of sort of the online way of advertising, a whole range of things, a range of areas that you can get advice on, then routing people using technology, in the back end having a way to track what people are doing and how much time they're spending on it so they can keep revisiting to say, do we need more effort in this area or that area? So given that that's an area, this is something that CS does really well, was there any discussion about extending it much more broadly than sort of in the typical areas of consultation? Because I think there's a real opportunity here. Here's a program that has developed some state-of-the-art systems, and this is something that we miss in many other things that we do, where we are looking for a sophisticated interface where people can go and ask any and all questions, a sophisticated interface that allows you to track how much time you're spending on them so you know where your costs are going and who, et cetera. So any such conversation or ideas people might have along those lines?
There weren't any specific conversations like that. We had some general conversations on how what CS has built here at UCSF might be then used at other campuses, but there weren't any other specific examples that we discussed at the time. Bullet point I forgot, take over the world. That was, that's the one I missed. Okay, thank you very much.
And then finally, Vanessa Jacoby, who will talk about biomedical informatics.
Great, so we had not one but 2 tables interested in biomedical informatics. So I think we actually decided between our tables we're pretty much the most important group because there were so many of us. But we also, even though we had separate discussions, we actually came up with very similar proposals and thoughts that I'll share with you. And we really talked about 5 things, and under each of these 5 things, we have a lot of strengths and also some suggestions going forward. So the first issue that was a common theme at both tables was that we have a lot of existing fantastic electronic databases at UCSF, but researchers are having a very challenging time being able to access and integrate those databases. We know that we cannot integrate all of those databases into common data elements so you could use them completely together, but we came up with this proposal where we could have a new platform in which researchers could go to and have, in an umbrella format, one way to find out what databases are available for my research question, how do I access them, and who are the experts in this area. So it'd be a little bit of a similar approach to what My Access is now, where you have one common login and lots of information under it. We do not have a title yet, but some acronym, catchy acronym. So you would go to catchy acronym, and let's say the example that we used was you had a question about what are the predictors of adverse eye disease for women with Sjogren's syndrome? So you could go to catchy acronym and use a search engine, and all of the databases at UCSF would be there for you. So you would have APEX or the EDW, which we're already working on, is in place. You could have the cancer registry, you could have genomic information, you could have the PPRNs and the CDRMs included in this integrated search engine. And so when you put in your research question, you would be able to say, here are databases that might be helpful to you. And then you can also address the second question, which is, who are the experts that can help me with this? And so this database also could bring in profiles, for instance. And you could say, here are the researchers that have used APEX for this research question about Sjogren's disease, and here's how, and they have, our consultants, say, connected to the CS. So it's really a new portal to manage all of these electronic databases to make them user-friendly and searchable for the researcher. So that's the tools part of this. But then the second part we talked about is having the people part. So a lot of the folks in our groups talked about even having access to these databases, that you really need expertise, concierge services to be able to manage them and have experts in that area. And both tables brought up the issue of not just experts in the content in the database, but also time and cost that it would take to address a particular research question. So for this new platform of being able to search in a user-friendly way the available databases, you have the tools piece, and then you also have this people piece. So the second issue that we talked about was data standards. This was a very common theme at both of the tables. So we believe there's a very strong need for not just common data elements across our databases and across UC Rex and UC Braid, but also metadata. So not just common data descriptions, but also, for instance, using the example of Sjogren's disease, that when you put in Sjogren's disease, you can see this is how we, in these databases, have defined Sjogren's disease, using these ICD-9 codes and these drugs that people have used and these outcomes. And we don't have that now, which makes these databases very challenging for researchers to use. So the third issue we talked about, this is really interesting, integrated into training, is data management services. So we do have in the consultation service data management consultations, but the issue came up that a lot of particularly junior researchers don't have the understanding about how to build a data management system and how to use it effectively. And one of the groups really talked about the need to have more support for maybe common data platforms, particularly for junior investigators, and that should be fleshed out further. And then the fourth thing was, both of the groups talked about the need for researchers to connect more using these bioinformatics platforms. So we have very nice ways that we do this with interest groups and profiles as a way to connect, but perhaps we could really ramp it up for the next 5 to 10 years, where researchers can find each other better online and have webinars around common methods, around common diseases, and there was a sense at both tables that there could be more connections using some of these electronic methods. So let me pause there and see if other folks at my table have things to add about this vision.
Hi, Leslie Ewan. I work, manage the virtual home program. So one of the things I think that we talked about, maybe overarching all of them, were the partnerships across the campus. And one of them was to leverage the fact that Joe Bengford is the CIO over the medical center and the campus right now, and getting the research agenda, sort of up on the list of things from clinical and billing and compliance and things like that, to working with ISU and their Salesforce platforms and the coordinates. And there's a lot of organizations that are doing things on campus, and CTSI could probably work more closely with them, figure out what partnerships exist that are already on the campus that should be leveraged, and that we should all be more integrated, because there is a disparate array of resources out there that are difficult to find.
Great. I'm to leave. Okay.
And finally, final Minnie Callon to talk about early translational research.
Hi, so we started with ETR's proposal, but we quickly put it to the side. It didn't hurt that we had the program director, June Lee, with us, who unfortunately, actually fortunately, didn't follow instructions and was not quiet at the table. Therefore, I think we got some great ideas from the group. We also were reminded in the group of partners that we've had for a while that we had forgotten about, which is a great thing about these retreats. You meet people and you say, oh, what is that acronym that you work at? Oh, wait a minute, we're actually partners. We're supposed to be affiliated. So you learn about an affiliate that we have that I certainly had forgotten about. We'll get there. But the strengths of the proposal, these are all new ideas, some contributed by June herself, actually touched on some similarities, some of the points that the BMI group brought up. So clearly, we don't have to go through this again, access to data is big. This was brought up at the ETR table as well. And we're thinking about all kinds of data. So there are data sets that exist that we don't even know about, connecting it to expertise, getting access to medical record data, even though it's doable. Many people in the basic science area or people that have, say, tissue banks may not know that there's actually a process you can go through to get some basic clinical information out from our EHR. So there's both getting access to the data, but also knowing that it exists and that you can get access to it. Some of it you can get access today. But then the big piece, two other things that we brought up were, one, that next-gen research for early translational research may actually focus more on the team science piece. So the question we asked ourselves is, have we actually moved the dial on bringing clinical researchers together with basic scientists? And our overwhelming answer was, actually, that hasn't moved very much. So next-gen research for early translational research is probably really looking at that problem hard and asking how we can try to fix it. And probably to do that, we'd have to try several things, because a couple are going to fail and maybe one sticks. And we had some ideas in that area. We certainly think that, just like BMI suggested, that there may be mechanisms to bring together groups based on diseases. But it also could be mechanism. We're talking about a new taxonomy of disease that doesn't start with a disease, but starts with a mechanism. So we'll have to figure out what it is that ties people together, but that we should put some effort in bringing them together. And there are two specific ideas. One, maybe we could use a proposal challenge approach that uses electronic media. So, given Hal's talk, maybe a first challenge would be about identifying sort of outlier issues that are interesting, and the top 3 would be selected, and that itself would have some kind of an award. And that mostly would probably be clinicians who contributed to that, because they have the expertise to come up with, to understand what's actually a really interesting outlier versus potentially noise. And then maybe that could be matched to the next round, where we open it up, take the top 3 and open it up to basic scientists to say, these are 3 outlier problems that clinicians have identified. Now, who wants to propose how to work on answers to them in the basic science domain? So that's one example that leverages electronic media, and we know something like that has to happen to scale some of these interactions. But we also think that in-person meetings still, or in-person symposium meeting discussion groups are still important. Because in the end, we were all agreed that you're going to need to model making those connections. So just having 2 people from across the spectrum talk is one thing, but to have somebody who understands some of the elements of both connect conversations, at least in the beginning, is important. So we were thinking about a discussion group / journal club, not like, in the past we've done examples where we had presentations, so the bulk of the time were taken by a clinician presenting on a topic and a basic scientist presenting on a topic, and then you had Q&A. We're not entirely convinced that that model would work, but what if it was a journal club and there were papers, or it was a presentation by an industry expert that comes in and describes the lay of the land in an area, but the bulk of the conversation would be facilitated conversation after that presentation. So we still think that some of these in-person events could be important, and we might be able to seed them with a little bit of money, do an RFP, 25K, like an SOS pilot, where we would ask for ideas from the population at large, and we'd give some requirements, and if they won in there, maybe you have 2 demonstration projects, and the demonstration projects would be convenings to bring people across something, some level of organization, disease, mechanism, something. And the requirements might be you have to have a clinician, an information scientist, and a basic scientist, and they have to come together to propose this. So those are some of the ideas that we had. We also noted that innovating around the IP domain is going to be next-gen research for early translational research. So there are some companies that are doing very interesting things, like Takeda set something up where they're putting their small molecule experts together with scientists in New York, and they've said zero claim to IP. So they've literally taken that piece off the table. That's really pushing boundaries, but like that, other companies may be more likely today to innovate. So maybe we should be looking at next-gen IP models and pre-competitive collaboration models as part of what we do for ETR. While I was speaking, I already mentioned many of the partners that should be at the table. Obviously, there's a whole slew of industry partners. A lot of people in the BMI profiles. The SOS Team Awards is already a great template to begin with for some of these ideas. And then the group that was at our table has a lot of great resources. That's the Blood Systems Research Institute, which is actually an affiliate. It's been on our website, that's why it seemed familiar, but we haven't done much with them. I'm just acknowledging that as the ED of CTSI, and we need to do more. So that's a great example of a group that has resources and tissue banks and folks, 4 people or 3 people at our table that are dying to share stuff, and we just haven't done it. So let's go back and look at our affiliates and try to get them promoted more in the resources they have. Anything I missed? Questions, other ideas? All right.